An intraventricular hemorrhage is a bleeding into the brain's ventricular system, where the cerebrospinal fluid is produced and circulates through towards the subarachnoid space. It can result from physical trauma or from hemorrhaging and stroke. In infants, this type of hemorrhage is particularly common in infants, especially premature infants or those of very low birth weight. The cause of IVH in premature infants, unlike that in older infants, children or adults, is rarely due to trauma. Instead, it is thought to result from changes in perfusion of the delicate cellular structures that are present in the growing brain, augmented by the immaturity of the cerebral circulatory system, which is especially vulnerable to hypoxic ischemic encephalopathy. The lack of blood flow results in cell death and subsequent breakdown of the blood vessel walls, leading to bleeding. While this bleeding can result in further injury, it is itself a marker for injury that has already occurred. Most intraventricular hemorrhages occur in the first 72 hours after birth. The risk is increased with use of extracorporeal membrane oxygenation in preterm infants. The amount of bleeding varies. IVH is often described in 4 grades. Grade I, bleeding occurs just in the germinal matrix. Grade II, bleeding also occurs inside the ventricles, but they are not enlarged. Grade III, ventricles are enlarged by the accumulated blood. Grade IV, bleeding extends into the brain tissue around the ventricles. Grades I and II are most common, and often there are no further complications. Grades 3 and 4 are the most serious and may result in long-term brain injury to the infant. After a grade 3 or 4 IVH, blood clots may form which can block the flow of cerebrospinal fluid, leading to increased fluid in the brain. There have been various therapies employed into preventing the high rates of morbidity and mortality, including diuretic therapy, repeated lumbar puncture, streptokinase therapy and most recently combination a novel intervention called drift. In 2002, a Dutch retrospective study analyzed cases where neonatologists had intervened and drained CSF by lumbar or ventricular punctures if ventricular width exceeded the 97th centile as opposed to the 97th centile plus 4 mm. Professor Whitelaw's original Cochrane review published in 2001 as well as evidence from previous randomized control trials indicated that interventions should be based on clinical signs and symptoms of ventricular dilatation. An international trial has instead looked at early versus late for intervening and draining CSF. Drift has been tested in an international randomized clinical trial. Although it did not significantly lower the need for shunt surgery, severe cognitive disability at 2 years Bailey MDI,